was a really useful thing to go further into maybe some of the conversation that I was starting to frame, which was if we make choices, every choice we make is a difficult choice. And we're looking at older people's healthcare, there are difficult choices to make. But I want to frame this half-hour rapid conversation in a different way. I want us to imagine the optimism that actually Chris ended with, which is that maybe in 10 years' time we have done something good, and we have managed to change the situation so that that life expectancy gap between the poorest and the richest has moved a bit, maybe 3 years, maybe 4 years. So we've moved it a bit. And the question that we've asked our panel, who I will introduce, to think about is, what has the NHS's role been in that? It's very easy for us often to talk about the really deep roots around social inequalities in healthcare, to talk about housing, to talk about education, to talk about transport. But actually, what could the NHS itself do to have made that impact, which means we've made a shift? So I've got with me Sally, who's a senior research fellow at the Health Policy. I've got Habib, who is the director of the Observatory, and I've got Martin McShane, who is from Optum. I'm trying to remember, you're the chief medical officer at Optum, and this session is supported by Optum as well. So I've set up that scenario. The NHS has played its bit in this amazing shift in society. Sally, what's the NHS had to do to get us there?
Okay. I'm going to talk about what the NHS itself has had to do, but also what others have had to do to facilitate that. So I want to talk first about what politicians and what central government has had to do. So what we think we've had in this 10-year optimistic vision of the future is a significant reduction in the healthy life expectancy gap. And I think for that to have happened, first of all, there would have to have been a really clear mandate from social government, from central government, and some political consensus that that was a legitimate target, that was an absolute priority target. I mean, we already now have a measure for that. That's the IMD score by decile, IMD decile, the healthy life expectancy gap between very small areas being the richest and the most deprived. The other thing that happened is that there was an absolute recognition from central government that flowed through to the NHS that the NHS does have a role. You know, of course, most of healthy life expectancy gap is driven by the social determinants of health, but there is a role to play for healthcare. Healthcare can't remove all of it, but it does have a big role to play. And what the NHS then looked at, supported by central government, was really exhausting the agency that it had there. So part of that, exhausting that agency, was first of all having that, that was facilitated by having this very clear mandate, and that would be a massive step forward. At the moment, the current government talks about increasing overall healthy life expectancy. I think there's a specific target to do that by 2030, but that's overall healthy life expectancy. There's only a very vague reference to closing the gap that exists, the 19-year gap between the most and the least deprived areas. And there's been some great work that Bowler's led at NHS England, but I think that's kind of been despite the lack of a really clear mandate from central government around that. And the opposition does actually want to switch that. The opposition party is talking about wanting to close the healthy life expectancy gap, but it's currently talking about the regional life expectancy gap, which is much smaller. That's 6 years as opposed to the 19 years between small neighbourhoods. And if that was a target, I think that's not strong enough, it's not ambitious enough, and of course it would risk the gains in healthy life expectancy accruing not to the most deprived within those regions. So that's kind of what needs to happen nationally. And then for local systems, local NHS organisations, I want to talk about two sort of buckets of action that I think have happened around this kind of maximising the NHS's agency. And so the first bucket, and I want to be possibly oversimplistic here, because I think sometimes discussions around health inequalities, we're not quite clear what concepts we're talking about and what we mean by certain words. So the first bucket is really to actually achieve equal access for each equal healthcare need, defined in a really vanilla way as equal healthcare need being, everyone getting the same, those who meet the treatment criteria, the national treatment criteria. This is nothing particularly ambitious or radical. It's the bare minimum, yet we know we don't have it. So achieving that is going to mean NHS organisations having to spend time and money on things that might look and feel like non-clinical inputs. So it's going to be things like transport, cultural competency, looking at clinic opening times, and addressing the hidden costs of accessing care. But getting to that stage, I think, is unlikely to exhaust healthcare's ability to close the healthy life expectancy gap, because we're still going to live, sadly, maybe I'm not as optimistic as Professor Whitty, but I think we're still going to be living in a society where the social determinants of bad health are unfairly stacked. And at the same time as well, of course, healthcare is implicitly rationed. We have waiting times, we have clinical criteria, and we have cost thresholds for quality gains. And I think the second bucket of action that the NHS would have taken, which is more radical and more complicated and tricky and potentially controversial, is to adjust the rationing criteria to place a greater emphasis on the value of closing the healthy life expectancy gap. And I think we've seen some efforts start talking about that and looking at that around deliberately reducing waiting times for deprived and marginalised groups. I do think personally, I feel that's a legitimate approach. If an elective procedure brings an increase in health-related quality of life, and we probably shouldn't be doing them if they don't, then providing that earlier for groups that experience the lowest healthy life expectancy will result in a closure of the gap. It's probably not the most efficient way to do it. The most efficient way is probably going to be to solve social terms of health, but that which needs to be happening as well. But I think we need action on both sides.
Okay, great. I love the idea. The NHS has got a lot of power. It's got things they can do, and that in this position in the future, we'll be able to look back and think they've grasped the opportunities they've genuinely got themselves. Habib, what has the NHS actually managed to do in this space?
Well, three things come to my mind. Firstly, the fact that the NHS, yes, it's an important player when it comes to tackling inequalities, but it's not the only enabler for equity. And when it comes to structural issues and some of the structural discrimination that we see within society, we need a system-wide response to what essentially is system-wide challenges. And that's where, theoretically, I do emphasize theoretically, the ICSs and the ICBs come into play to bring together those players that can really focus on those system-wide issues. When it comes to older people, as Chris highlighted, we know that very often those barriers for older people are structural and they are embedded within society. And of course, our focus must be as much on the barriers as well as the lifestyle and the way that people behave. And the focus needs to be on both and not one. And that's two sides of the same coin with regards to action. But deprivation is an interesting area as well. And if you're not looking at what we call the causes of the inequalities, then very often you're looking at this kind of surface level issues, and you're not going to have the sustainable, meaningful change that we need. And deprivation tells us where the inequalities exist, but not necessarily why they exist. And unless you look at a kind of a holistic approach to deprivation and tackling inequalities, such as we do with, for example, the Core 20+5 program, but linking it with kind of the structural issues that we see in society, you will not get that meaningful, sustainable improvement in inequalities. But the NHS, I always say, is a fantastic institution. It's perhaps the most vivid example of a social contract between people, and we saw that so clearly through the pandemic. But to be proud of our healthcare system is not to be blind to some of its imperfections, and the imperfections that we see in the terms of the stratification in access, in experience, and in outcomes are some of those imperfections. And if I just give a very quick example of kind of not focusing on the causes of the causes that then leads to the inequalities that we see. Earlier this morning, we talked about the lack of representation in clinical trials. And for us at the Race and Health Observatory, that's very important to focus on, because that lack of representation in clinical trials does lead to bias in medical devices, bias in clinical assessments, and bias in drugs and medications that are therefore not kind of tailored to meet the diverse needs of our diverse communities. So I guess in conclusion, a focus on the barriers of inequalities as much as to the behaviors and the lifestyles of those that experience those barriers. And if we are able to do that, then I think we can get kind of meaningful and sustainable improvements on the inequalities agenda.
Yeah, so again, a range of things that are within the health service's power to do, because often the conversation can become a bit circular and a bit disempowered. I mean, Chris was clearly very, was optimistic about the possibility of change, but I am going to come back and ask maybe all three of you, when I've listened to Martin the first time, to reflect on what do you think the challenges are about what Professor Whitty put to us in terms of our need to, put our SDI clinics in the city and put our coronary heart disease clinics on the coast. What are the equity challenges around all of that? But I'll come back to that. Martin, what's the NHS done that has allowed us actually to feel positive in 5 years' time, of 10 years' time, that we've made an impact on health inequalities in access?
Well, I think there's kind of, again, a focus on three things. The NHS is using integrated data, armed with HI. And HI is human intelligence. Because my experience of using integrated data with the NHS over the last 5 or 6 years has been that it is essential to really understand the challenges you're facing, but it's insufficient until it's given meaning with the insights, knowledge, and experience of frontline professionals. It is inadequate on its own. And I think we heard that from the AI as well, that it's a tool, but it's not, it's an end to a means, not the end in itself. And the second thing about using integrated data, I think that the NHS will have switched off some of the ways it thinks about addressing things at the moment. And here I will be controversial. It will have stopped looking at everything through the lens of conditions, organs, and organisations, and will have started to focus on complexity and risk. And that will have got rid of a limiting assumption and that age is important.
Haven't we just heard that age is really important?
The data shows us that there are changes in complexity and risk across the country for various reasons. Mm-hmm. But when I worked in Eckington, an ex-mining village, and worked with the population of Bolsover, people just got older, younger there. They were old at the age of 50 compared with people aged 70 or 80. So it's not age per se, it's understanding people's complexity and risk. And integrated data, you look at everything that's happening to a person through the eyes of what is happening to them across the system. Not what's happening in general practice or on acute trust or community or mental health. You see their journey across the system. And it is revelatory in understanding how we can better harness the strengths we have. And that's the other big change in the NHS in a few years' time. It is taking a strengths-based approach to addressing these problems by truly understanding the complexity of risk of individuals, families, communities, place, population. And that allows it to focus its strengths in an important way, so we get rid of the tyranny of the average. Sorry, Bola, I'm nicking all your key phrases. But we get rid of the one-size-fits-all. And to give you two examples of where we've worked with parts of the NHS already on this, one is with a big acute trust to look at their waiting lists and people with learning disability. And when we showed them the data, when we revealed that data to them, they realised that the way they were managing people with learning disabilities was basically disadvantaging them and giving them worse outcomes. So they now have taken that cohort out of their tyranny of the average, their cab rank process, and given it special, but they've now realised they need to do that in more ways than ever with their waiting list. The second is with Cheshire and Merseyside, looking at fuel poverty and COPD. And actually giving them the information of overlaying where, if you're going to throw resources at fuel poverty, throw them in this area because you will get better out. So it kind of chimes with what Chris is saying. Focus your strengths where they're most needed. But when I was a GP in the 1990s, we had a welfare benefits officer have 2 surgeries a week in our practice. There was never a day I went by when I did not refer, because I had the agency to do this, as you were talking about, to leverage the other assets that I knew about in the community to benefit the people that I was seeing. So I think the NHS has massive agency on this agenda, both within itself, but also to leverage external assets to the benefit of the people it's serving. So that's where I'll leave it for now.
Okay, so we've got some views about all the actions that the NHS could be taking, and it's all within their power now to be taking, but some of them are quite controversial, as you said, like the different ways of managing waiting lists, different ways of taking cohorts out, different ways of focusing on groups and people. When you reflect on what Professor Whitty was saying, are there any challenges for the broader health inequalities agenda to have that challenge in the mix of an older ageing population who's moving out of the cities, but we know we have a lot of poverty left in the central areas of the city? I mean, Habib, are there challenges around how we manage all of this at the same time?
I think there are probably 2 challenges that come to my mind. One is an internal one for the NHS, and that's the fact that if we're in the business of tackling inequalities and health inequalities, which we are, then we need a workforce that's fully supported and engaged at all levels. What we saw earlier today with the release of the latest NHS staff survey data is that actually discrimination, victimisation, bullying and harassment for staff generally, but particularly so for black and minority ethnic staff, which constitute now nearly 25% of the total NHS workforce, has remained static or has gone backwards slightly. And we know of the relationship between engaged staff and better outcomes for patients. So that's kind of one challenge. The second one is an outward-facing one, I guess, for the NHS, and that's particularly so as we navigate ourselves through the pandemic and come out through the other side, is to build and rebuild levels of trust with our communities. Trust can be broken down into kind of truth told consistently over time. And when any part of that equation breaks down, you have a breakdown in the levels of trust with our communities. And what we've seen, particularly over the last 3 or 4 years, is trust becoming a new determinant of health, influencing people's decisions around whether or not to take up medications or vaccines, etc., but not just in relation to those. And when it comes to prevention, when it comes to delaying disease, those concepts are critical.
Yeah. Sally, are there any challenges if we take on the whole of Chris Whitty's challenge to all of us? How do we balance it all?
Yeah, I mean, first of all, reducing the healthy life expectancy gap is absolutely key to what Chris was talking about, because people in deprived areas age at a much earlier age and for much longer, from 51 to
Which is a bit 75. What Martin was saying, the people he saw were elderly, but they were 50.
Yeah.
Yes.
Yeah. So they are part of the same piece. I suppose geographically, in terms of the shifting the physical resource, there is a tension and a potential issue there. But I thought it was very interesting how Professor Whitty was talking about having those conversations with people about what an older life, a dignified old life is. Old.
Yeah.
You know what I'm saying.
We all know what I mean.
And that what we don't know is how that might change healthcare resource consumption. Because we don't have those good conversations at the moment with people at later age.
Yeah, I think that's right. I just want to open out. We've got about 10 minutes, then we're going to have a cup of tea. But it's really just continuing the conversation about, here we've got 10 years on, we've managed to actually shift the dial a bit. We've managed to do some of what Professor Whitty has put to us as a challenge. What other things should the NHS have done and got involved in? There's a gentleman at the back with his hand up.
Hi, thanks very much. Really interesting discussion. I'm John Ford. I'm an academic public health doctor from Queen Mary University and Director of Health Equity Evidence Centre. So 20 years ago, we had a cross-government health inequality strategy Our research, plus others, has shown that was successful in reducing the health inequality gap by about 6 months, and also reducing inequalities in infant mortality. The mistake that was made at that point was we didn't learn the lessons. So we knew that inequalities were reduced, but we didn't know why or how. We know that the NHS was central to that. We had health equity audits done every year. We had a national inequality support team. So I guess my question to the panel is, you know, we've currently got lots of health inequality initiatives across ICBs, hospitals, PCNs. A lot of it's driven by Bola's Core 20+5 approach and her team, which is great. How do we innovatively collect data, build the evidence base, and learn the lessons so we can make progress on evidence-based solutions to what works to address inequalities?
Okay. Anybody want to answer?
Yeah.
Go on, Martin.
No, I think I go back to the point I made about data earlier on. I think the NHS has a wealth of data which can be used, and it doesn't have to be overly complex. And we've put together, over the last 5 or 6 years, we've put together integrated data sets across 36 ICSs and shown professionals, executives and clinicians where they can see where their problems are. And if you had that, if in 5 years' time we had that live, usable data and could track, and we're starting to do that, set up evaluation, you can actually, within that, evaluate the impact of your interventions and properly assess with real-world data, because everything we do is a hypothesis. We believe this is a complex adaptive system. We believe this intervention will have this desired effect. So let's test the hypothesis, and that would turn us into a proper learning system. I know that we had the reference to a learning health system under AI. I don't think you need AI for that. I think we could do it now with what we've got, the strengths we have across the system. So I think it's a very exciting time if we can build that trust in how the data will be used.
Okay. Lady in the middle here.
Hello. Ooh, there we go. Hi, Emma from Understanding Patient Data. Just following up on that data point, we hear a lot about how we can use data to, drive improvements in population health and reduce health inequalities. But thinking, and this is perhaps me being a bit data geeky, but thinking about the sort of technical infrastructure enablers of that, what would you say, this is perhaps more from Martin, organizations that are able to do that well, what would you say sets them apart, and how can we sort of spread best practice to make sure that whether it's systems or trusts or other organizations, that they have what they need to be able to do population health management well?
I thank you. Very simply, I think it is about building trust by starting locally, by getting people experienced and seeing, so they taste, see and feel the data and can see how they can use it to do what they come into work every day wanting to do, which is to improve outcomes for people. And then that spread also, I think the other big thing we haven't talked about, the challenge, is how you use it then to change the nature of the incentives we use across the system to stimulate people to work in rural areas, which we will need. Chris Whitty's absolutely right. We will need more resources, but how do you get people to work on the east coast of Lincolnshire? And I know because I worked in Lincolnshire for 6 years, that's not easy, but there's some very dedicated people who go there. So I think it's how we use the data and how it's used intelligently with people to help them do the job they want to do. Too often at this moment, it's not really used in that way.
And it's all got to be aligned, hasn't it? It's what Professor Whitty was saying, which was, all national policy needs to be aligned. You need to have everything. So, a colleague who talked about housing, you've got to support housing in rural areas. You've got to support the whole way in which everything goes together to make that come together.
One quick point. United Health Group, American healthcare company, has invested $800 million in social housing because it has the data and can see the benefits. And I was quite astounded when I found that. I never thought an American healthcare company would do something like that. But oops, I'm going to get sacked.
Lady here, and then we'll go and have a cup of tea.
Hi, Charlotte Williams from Midland South Essex, NHSFT. I wanted to ask about the role of providers in this, because in my ICS, my organisation takes 69% of all the resources available. Do you think through understanding inequalities and personalising actual healthcare delivery, there's ever an opportunity to release the resources back to intervene in inequalities where it makes more sense, so more locally, and in settings that aren't expensive healthcare? So, because we know it's inefficient at the moment, do you think we need to move the money? How can we make it happen from a provider's perspective? Thank you.
Really interesting question. Sally, do you want to have a go? And Habib and Martin, then we'll...
I might not have heard all of your questions, so apologies if I've misunderstood it. I really worry that healthcare inequality interventions or policies are expected as standard to deliver a saving. Like, we don't ask other healthcare interventions to deliver a saving. I mean, very few. Why is it that underserved groups, in order to justify serving them, bring the service they get up to the level that everybody else already gets? Why is it that that has to stay? And I think the reason it is at the moment is because there isn't another national mandate to do it. You know, the national mandate is to live within the budget. And if you're going to do anything other than what you're already doing, then you need to basically make it self-funding. So I think that's why it's the importance of having a very strong steer from central government that reducing healthy life expectancy is in and of itself a priority. And it probably will mean spending more money. And if there isn't more money overall, then there will have to be less done elsewhere.
Which maybe gets into the quality quantity type conversations we had. But I think it's a very hard question to answer. But Habib, have a go.
Thank you. Well, obviously, tackling inequalities will make, you'll make savings as a system, as an organisation, as a society as a whole. But it's also about, and critically, the impact that you will have on people. Because we've talked about data, but behind data are people, and that needs to be at the forefront of our minds as we kind of tackle inequality. So yes, at provider level, absolutely, but as we've talked about earlier, some of these issues, some of these challenges are structural and system-wide and need to be focused upon with the different players that come together at system level as well. So I always say kind of national guidance is great, national frameworks are great, but they need to be national and tailored towards local areas, and within local areas as well.
Right. So I'm going to release you all back into the wild, and you can go next door and we'll have a cup of tea and a break. At what time do people need to be back? Because I haven't got it in front of me. Anybody?
4:30?
No? 4:35. 4:35 and you're back. And could I please ask you to spend some time looking at the Nuffield Trust posters that are around in that room as well. I'm sure there'll be colleagues who will be near them and able to talk about them, but I know people would really like to talk about the work that they've put on the posters, which would be great. Thank you very much, and thank you to the panel.